Okay. Hello, everybody. Today we are having a new seminar at the Center for Health, Humanism, and Society in the Negev. Our seminar is with Professor Clarfield, Mark A. Clarfield. Originally, he was a family physician from Canada. Then he became a geriatrics expert, a specialist, and took several management functions in hospitals. After he came to Israel, he became the head of the division for geriatrics at the Israeli Ministry of Health. And in Soroka, also he was heading the section. And later a member of staff at Ben-Gurion University. Eventually the head of the Medical School of International Health. And that's it. We're happy to have you. And I will let you introduce the title of the lecture. Thank you very much.
Thank you, Rami, and thank you very much for the invitation, and especially to all of you who are listening today. Some of you, I'm warning you already, some of you have heard part of this lecture before, but I usually do change them in between, so there will be some new stuff. I'll try and irritate as many people as I can this afternoon. There is a word, indeed, missing. I don't know why it's missing from the topic. It should be age, aging, ageism, gilanut, and agitation in the age of COVID. Now, for the Hebrew speakers among you, this is not a real word. This is a word that I invented, but obviously it comes, if you get rid of the E, it becomes agitation, because I think there's a lot of hafra'ah and a lot of bilbul and a lot of heat and not so much light sometimes on this issue. So I'd like to try and, as we say in Hebrew, lasot seder, make some order out of some of the things that you've heard. It's possible you won't agree with me, but I do hope that at least the presentation will be logical and we can, Rabbi, remind me how much time we have? So I would like to leave time for questions. So how much time do you want me to take?
Well, we're thinking about like maybe 40, 50 minutes. And,
okay.
And then
fine.
questions, but it depends on you if you want.
Oh, no, that's fine. Rami, if you could just, if I go past 45, if I go at 45 minutes, please let me know. I should finish before then, but if I don't, please, you know,
No
a friend of mine once defined, he's a psychiatrist and a very good one and a very good lecturer too. And he defined something he called the speaker's delusion. And the speaker's delusion is the psychiatric phenomenon that occurs when you have the microphone and the attention of the audience, in which you think that every single word that you say is of utmost importance, and every single thought you have has to be expressed. And of course, that's not the case, but it's a delusion that many of us fall into, and it makes us speak too much and for too long. And so I always ask a friendly critic like Rami to please tell me when I'm going on too long, because I would also like to give the younger faculty who are listening today a tip. One of the ways you get promoted in the university is via student evaluations. It's not as important as it should be, but it is important. And one way I learned to get good evaluations is always to end either on time or 5 minutes early. So even if you spew nonsense for 40 minutes, but you don't go on too long, people will love your lecture. So I'm going to try to say something sensible and not go on too long. So let's move along. You can hear me and see me okay? And the slides, most importantly? Okay, so I'd like to dedicate this lecture to the memory of my father, who died at age nearly 100, just a year ago, almost today. And he was an interesting fellow. I don't have time to go too much into him, his life, but you can see if you're a clinician, he looks pretty good. This is a week before he died. And he was quite with it, and I was in London at the time, and this was a minute after I got into the hospital. He said, "What are you doing here? You're supposed to be in London." And I said, "You're right, Dad, but I heard you were sick, so I had to show up." So he has an older sister, my Aunt Rose, who today is alive and is 103. And she just got discharged after admission for COVID-19 in Toronto. She was admitted, she was positive, she was there for 3 weeks and just went home a week ago, and she's fine. So everything I'm going to say about age is completely wrong when you look at someone like my aunt. But she is really what I call the exception that proves the rule. And I hope you'll understand what I mean by that soon. Anybody who hates old people, and I'm sure there's none of you here in this audience, but if you do, you even if you hated them, you have to see how many of them there are going to be by sort of 2020. This is the area under the curve for people age 70 in the world. There's a lot of children, of course, but there is an absolute growth. When I was born in 1950, this is 1950, this is the number of people over age 70 there were. This is the number of people over age 70 there are today. Triple, quadruple. So even if you don't like old people, there's going to be a lot of them and you have to pay attention to them. So I'd like to ask Arba Kushiot, fear questions, Shaylis, four questions today. Is age a risk factor for COVID-19 for death in otherwise healthy elders? What is the effect of comorbidity on this factor? If age is an independent risk factor, what should we tell older people? And what is the problem and the challenge of this term ageism in this discussion? So that's what we're going to talk about. And I'm going to try and do it through the lens of medical ethics that looks at the four principles that are all worthy, but sometimes they bang into each other. Sometimes there's a conflict between and among these principles. And I'll try to remind us when we're talking about an issue, which of the four principles of medical ethics we're talking about. And I think that that's perfectly appropriate for a center like Rami's that deals with humanism. Am I right? You're okay with that? Okay. So before we go on, we have to define aging. Here, this is a graduate course in one slide. What causes biological aging? It's really the gradual failure of an otherwise excellent self-repairing machine. As we sit here doing this lecture, there are all kinds of breaks and mistakes being made in our DNA and RNA, which come from endogenous and exogenous sources. And if we didn't have this fancy, mishuchlal, sophisticated DNA repair mechanism, we would die in a very short period of time. But it's extremely, extremely efficient in Homo sapiens, enabling us to live because of its constant repair many years. However, no system of repair, no car, no body, no house, no building can stay alive forever. However much you try and repair it, eventually it will disintegrate and fall apart, and the same thing with us. That's Gerontology 101. Oncology 101 says that there's a relationship between failure in DNA repair mechanism in cancer and aging, which we don't have time to go into, but those of you who are clinicians will know that 90% of cancers in humans occur in people over age 65. So there is an interesting connection between cancer and aging. Again, that I don't have time to go into, but what they have in them is a failure or a breaking or a mistake in DNA repair. And that gives us, in the end, clinically, for the clinicians among you, it's basically old people who are healthy, not sick old people. Healthy old people suffer from a loss of clinical reserve. They also lose psychological reserve and perhaps financial reserve and social reserve. And we have Stav Shapiro here who's helping with the project, looking at older people who are stuck indoors and have lost their social reserve because of social distancing. So aging is not a disease, but what it is it's a loss of reserve, so that when you do get sick, you have less to fight with. And here's a good example. These are kidneys and adult knees. And although your adult knees work very well, they can't handle stress as well. They can't handle stress as well as young kidneys because they don't have the same reserve, even if you don't have renal disease. So is age a risk factor? Let's look into that for a minute. Now that we know, yes, well, that's a pretty interesting, that's a pretty chad mashma'i, how do you say chad mashma'i in English? A pretty clear statement. The answer is yes, and it's yes with an exclamation mark. And the reason I put the exclamation mark is there's some people in Israel and abroad who, for whatever reason, find this fact very hard to accept. And I understand, as a 70-year-old, I also find it hard to accept, but it's still true, and there's nothing we can do about it. Well, there's not nothing we can do about it, but there's nothing we can do about the fact that the older you are, the more likely you are to get a complication if you get COVID. I'm not so sure that older people are more susceptible to disease. We don't know that. But if they get it, they're more susceptible to complication, pneumonia, intensive care unit admission, ventilation, and death. And it shouldn't come as any surprise to us, since we know that age is a risk factor for lots of diseases. And here's another tip for the young lecturers in the audience. The way to get good evaluations with students is not to do the following. Age is a risk factor for other diseases: ischemic heart disease, cerebrovascular disease. There's no reason to read every word on your slide. People are intelligent, they can read, and you say the things that add to you say the important things that add to your slide. You don't have to read it. It's not an article. Anyway, the point is that age is a risk factor for lots of things. Why shouldn't it be a risk factor for COVID-19? Here's an example. Let's just look at viral pneumonia, not COVID. Negev, just by coincidence from China, where this whole thing started, but that's not why I show it. I show it because it shows you that age, when in a multifactorial analysis, multivariate analysis, age 60 minus 60 over 60. If you're over 60, you've got twice the chance of dying from viral pneumonia than you do if you're under 60. So if all viral pneumonias act that way, why shouldn't COVID-19 act that way? And here's a COVID-19 slide, which looks at deaths in Italy. These are the Italian data, and these are the Chinese data. And you can see that the older you are, the higher the case fatality rate. Case fatality rate is a percentage of people who die who have the disease, not the percentage of old people who die, but the percentage of the population at various ages that dies if you get the disease. So in Italy, 20% of those people who were over age 80 who got the disease in this study died. In China, it was a little bit lower, but both show you that age, as you rise up in the age category, you're more likely to die. Now, some people will say that age is a marker for age-related diseases, and it's not age per se, but it's comorbidity. So we'll come back to that. Here's another study. This looked at Italy and China. This colorful study looks at age groups 0 to 9, 80 plus, and the colors are 4 different countries. It's a little hard to see them. I'll read them to you. The blue is South Korea, Spain, China, and Italy. So 2 of the countries in the previous slide. We've added two more countries, and we see that death from COVID goes up starting age 50. At age 50, you see a rise that is asymptotic and goes to over age 80. So this is another slide. Again, just looking at age, not taking into not controlling for, whoops, you can't see me there. See me all right? Sorry about that. So I think I've established, and there's many studies that show that age is a risk factor, but what about defective comorbidity? Because all of the slides so far, if you controlled for comorbidity, might turn out to be that age is not a factor. And why is this important? Because I've got colleagues, this is a quote from an older colleague of mine, whom I like and respect very much, but who claims, along with many other older persons, that he's a healthy 80-year-old. And he claims he's healthier than many 60-year-olds. And he says, in any case, comorbidity is more important than chronological age. And even more so, he says, to claim otherwise is ageism. And I'm telling you, I've looked after frail elderly people for 40 years, and I was surprised, but anything can happen anytime if you live long enough. I was surprised to have been accused of ageism after 40 years of devoting my life to old people. But still, they could be right. I mean, you could be a gynecologist and look after women for 40 years and still be a sexist. It is possible. But I don't think I'm an ageist, and it's not enough for me to claim that. I'm going to try and convince you that showing data about old age, even if it's bad news, is not ageism. We do have to be careful about ageism, and I'll come back to that. I'm not saying that this isn't a serious problem, but it isn't a manifestation of the fact that old age alone is a risk factor for COVID. Here's a better study because it's multivariate, and it looks at age as well as these other characteristics here. And if you see that these other characteristics, of course, cause, this is death. This is hospital admissions. Am I right? Is it death? Just a second. This is, yeah, it's survival, right? So this is a mortality, and you can see that all of these comorbidities have a higher hazard ratio than one, but age has an even bigger one. I'm going to get you guys out of the way here for me. Okay, that's 50 to 69, 70 to 79, 80 plus, taking into account, controlling for these factors here, these comorbidities. They're not all the comorbidities, but a large number of them. That's pretty demonstrative to me. It's bad enough if the absolute crude age-related numbers are like this. It's worse if it takes into account these comorbidities. Then I want to show you a curiosity. This is a study I showed a couple of weeks ago from the New England Journal, showing something similar. I won't go into the details. It controlled for these characteristics. It showed a similar odds ratio of 2, but this is a fascinating story, which I don't have time to go into. This study was withdrawn. It was published in 1st of May, and it was withdrawn from the New England Journal, which is something that rarely happens. But it was withdrawn because the author, Mera, who also had to withdraw a study from the Lancet, how embarrassing, was found he could not back up his data when people asked him for how he got his data. He'd gone to some kind of private company and couldn't. So that's a fascinating. Oh, I see my friend Michael Gordon's online. Hi, Michael. So we have people watching from Toronto. Here's another study that looks at the claim that my friend who said this is age groups and this is number of long-term conditions, comorbidities, okay? So 9 comorbidities, 0 comorbidities. Let's look at the 80-year-old, my friend, who is 80, has no comorbidities. He has on average around 10 years left to live in the cohort 80 to 89. And so let's look at how many years a 60-year-old has left to live if he has comorbidity. And he has to have 5 comorbid conditions before his life expectancy at age 60 goes below the life expectancy of a healthy 80-year-old. Okay, so a healthy 80-year-old has a lower life expectancy than a sick 60-year-old, showing that age itself and comorbidity contribute to mortality from COVID. It's not just comorbidity. Comorbidity does not explain all of it. It makes things worse, but age itself is a very strong independent risk factor. I think I'll skip over that. So to come back to the question, is chronological age an independent risk factor? The answer, ladies and gentlemen, is I'm afraid it is. Okay, but there are other categories. Age alone is not the only one, and therefore we should not just use chronological age in our discussion about COVID. And we never, as geriatricians, and I was taught by my friend, Professor Gordon here, who has just joined us, that age alone is not something that you use to make clinical decisions. But to ignore age is just as, in my view, is just as foolish as it is to use age as the only characteristic. So there are other things, and I'm talking to educated people here. Socioeconomic status is extremely important. Comorbidity, of course, we talked about. Race, ethnicity. In the UK, they've got this term BAME, Black, Asian, what's the M stand for? Multi-ethnicity or something like that. What they mean is the minorities in the UK. When you control, even for socioeconomic status, comorbidity and age, they seem to have a higher mortality from COVID than would be explained by these other factors. And there's all kinds of theories. The one that convinces me the most is that they're most exposed to the virus because of their immigrant background and their race and their class. They're people who are in the front lines of the NHS and poorly paid workers in what the Brits called care homes, what we call most CUD, nursing homes. And then frailty, there's a recent study that came out in the Lancet just last week that showed that frailty itself is an independent risk factor, but so is age. So it's not that these aren't important, they are important. And please don't take away from this discussion that I think they're not important. It's just that, again, age alone, the bad news is it's a risk factor. Oh, here's the Lancet study showing survival with time since hospital admission with COVID, and this is the CFS, which is a frailty scale. I think it's a frailty scale from Dalhousie in Halifax, the Canadian frailty scale. Anyways, it's a frailty scale. What does it stand for, Michael? Do you notice?
I don't know. Don't ask.
Don't ask.
Don't ask.
Okay. It's a frailty scale. Am I right?
Yeah.
Okay. So the frailer you are, the worse your chances of survival. And this is controlling for age. So young, frail people don't do very well either. Okay. So it's a risk. Age is a risk factor alone. Comorbidity makes things worse. What should we tell, given the above, what should we tell older people, and what should we tell the Ministry of Health? What should we advise the ministries of health? Well, here's a very confusing diagram, and I apologize for the non-Hebrew readers in the audience, but you can see the colors: green, orange, red, and it was meant. If you look hard enough, and it takes a while, you can find it on the Ministry of Health website, but it's hard to find. It's meant to warn people when you're at regular risk, high risk, or super high risk. And it's hard to understand it, except the bottom line is it does tell people at age 70, you're worse off than people 0 to 69. That's about all. The rest of it is, it's not that it's untrue, it's just not user-friendly. So my first bit of advice to the Ministry of Health around our own and around the world is to make clear guidelines for older persons so they know what to do. And should you warn them to be worried at 60 or 70? Well, if you think back to a few slides ago, it looks like things start to get worse around age 60. Even young people, of course, can get quite sick with COVID, but that's a rare event. So I think it should start at 60, not 70. And here my Canadian friends agree with me. The Canadian Geriatric Society put out very simple guidelines. I think they're not simplistic, they're simple. They say the best way to prevent illness from coronavirus is to avoid virus exposure. Masks, right? Masks, social distancing, washing your hands. And whenever I see somebody outside in Israel without a mask on or picking his nose, I say, you should be doing this. And when I see our own political leaders not doing this, it drives me crazy. The Canadian Geriatric Society said very simply, high risk is 60 and higher, and or. Those are very important preposition. Are those prepositions? Yes. Meaning that if you have these other things, it's bad too. But even if you only have age 60 and up, it's bad enough. That's pretty clear advice. And I think that our own Ministry of Health and our own relevant people should be putting out this message loud and clear to older people. And my Aunt Rose, and Michael, you didn't see this because you came a bit late. She just got out of a hospital in Toronto with COVID. This is my Aunt Rose Maury, my father's older sister at 103. She's an exception. Everybody likes to point to people like my Aunt Rose and say, oh, you see, this 103-year-old, God, she's okay. What do I need to worry about? I'm only 70. Well, she's the exception that proves the rule. What other advice? Sensible social distancing. Enjoy your grandchildren, okay? It's not that the kind of advice we gave old people initially in Israel was you had to stay in your apartment and lock the door. And your children, you could only see your children on Zoom. Well, that's not true. In my view, the evidence supports you being able to go downstairs, sit in the garden a couple of meters away from them, wear a mask, don't hug them, and just chat. And if they were 2 meters away from you outside in the garden, there's no significant risk. And so for people to be alone and socially isolated because we gave them terrible advice, that's not the virus, that's the Ministry of Health. We have to involve the HMOs. They have to make sure that people who are shut in, who can come down, they may be able to see their kids in the garden if they have a garden or out in a public park, but it's hard for them to walk to a clinic or go to a clinic for services. It may be difficult for them to get their medications. That has to be organized. And everybody has to wear masks. This is a no-brainer. We just have to do it. If I wear one and you wear one, it doesn't reduce the risk to zero, but it reduces the risk significantly. The other important thing, and here's a really sad story, we know that older persons and younger persons are avoiding going to hospital when they have sentinel signs such as chest pain or signs of stroke or diabetes out of control. That kills people. It's much better to go to hospital and look after your heart attack than to wait a week and come into the hospital too late. And so there are a lot of people dying at home. We know this. There's excess mortality going on around the world, in part because people are afraid to come to hospital. I mean, you've got sentinel signs, come to hospital. Get lots of exercise. No reason why you shouldn't walk around outside. Make sure you don't get fat eating junk food. And what I say to everybody, including myself, and sometimes I don't even believe myself, but it is true. We know from a study of history, all epidemics start, plateau, and end. This will end. So too did the 1819 flu pandemic end. It took a year and a half to end, and we're only half a year in to this one. This might take 2 years. This might take 3 years. Assuming we get a vaccine earlier, it won't take so long, but it will end. So people who have the end of the world view of this, it's bad, but it's not that bad. Now, it's hard to tell young people who've been laid off, who can't pay their mortgage, and who are at the end of their tether, that they should be patient for 2 years. I'm not saying that. I think the government has to do as much as it can and more. We have to work together. And I told a friend today, I'm generally someone who doesn't like to spend money. It's not that I'm cheap. I don't enjoy retail therapy. Some people some people feel good when they go shopping. I never do. I shop for what I need. But since this thing started, because I can afford it, I'm spending like a sailor. I'm buying whatever I can. Why? Because I feel badly for the people the restaurants that are closed. I went to a shoe store in my neighborhood the other day to buy shoes for my grandchildren. They didn't need the shoes, and he's more expensive than them all. But I said, you know what? This guy needs the business. So I bought 4 pair of shoes for my grandchildren. Everybody's happy. And I'm not saying that this is going to solve the problem of the economic crush, but we have to, those of us who can afford it should give to charity and buy things. And another cute story, I think it's cute. Yesterday, I was home, self-isolating, and the doorbell rang. I went downstairs, and there was this old chassid who said, can you give me money for the food bank? So, I felt terrible because I know that people are hungry, need money for the food bank. And I said, well, can you give, I don't like to just give money on the street. I mean, are you official? Are you, who are you? He said, I can give you a receipt. But I was skeptical and I felt badly. I sent him away. I said, I don't give money to people on the street. So what did I do? I went to my computer and I donated 200 shekels to a food bank that I trust. I mean, I'm telling you about this because we're all so mixed up. We don't know what to do. I'm trying to do my best, and I hope we should all pull together. This will end eventually. Okay, finally, let's look at this business of ageism. Is it ageist to use chronological age in our consideration? So first of all, what's ageism? The WHO defines it very succinctly. Stereotyping, prejudice, discrimination against people on the basis of their age alone. Now, usually this is a bad thing. For example, I had to retire from my job at Soroka and Ben-Gurion University because I turned 67 and 68. In fact, I got an extension as a charig, as an exception, but eventually I had to retire because of age in Israel. And my friends in Canada don't have to retire because of age. And I think that this policy of the university, it's the government policy in Israel of making people retire from university jobs because of their age is an example of ageism. Now, personally, I have to tell you, I'm having more fun retired than I did when I worked, but that's a personal thing. It is ageism to make us retire. Is it ageism to, do I have this here? No, okay. Is it ageism to make a commercial pilot at age 65? The rules around the world are commercial pilots have to retire at age 65. They could be perfectly healthy, but I'll tell you something. Who among us would feel confident watching 2 healthy 90-year-old pilots walk to the front of the cabin and you get on the plane from Tel Aviv to Toronto? I'm telling you, ladies and gentlemen, I wouldn't feel comfortable with that. And they could tell me they had a stress test yesterday. I still wouldn't feel comfortable. And most of you, I think, would not feel comfortable. So sometimes we do have to use age as a characteristic. Sometimes we do, but we should not do it without thinking very carefully about it. And where does this come from? Well, we're ambivalent about age. A long time ago in the 17th century, Jonathan Swift, the great writer, Gulliver's Travels, who died at, in those days, life expectancy was about 35. So he did pretty well. He said, everybody wants to live forever, but no one wants to grow old. I think in that sentence, that summarizes it all. Who wants to die tomorrow? Nobody. Who wants to look at the mirror and see this? Nobody. So what can we do? That's life, okay? And I think that the other thing about ageism is we have to really be careful that we're not causing problems to old people. And what Liat Ayalon said, and she said it right. She said I've spoken to her. She says, yes, I agree with you that chronological age is a risk factor, but we have to really be careful what we say in society, because it's to be flippant about that and to just put old people down and say you've got a risk factor, stay in. That's also dangerous. Okay. But people take this too far. My older friends have said, quote, chronological age should never be used to decide X, Y, or Z. And I think that that's not right. Here's the British Gerontology Society Association came out a couple of months ago with a statement similar, saying they should not use chronological age. A coalition, and maybe some of the people in the audience belong to this coalition, of the Israel Gerontology Association and 4 other groups, wrote a report and sent a report last week or 2 weeks ago to the United Nations, of all places, okay? Not the most Israel-friendly place in the world, but okay. The United Nations asked for opinions around the world whether ageism was being promulgated in their country. And this coalition of people whom I like and respect, I like them both. I think they said something wrong. They basically said you can't use chronological age because it's ageism. But so, to use the example, is it sexism to point out that breast cancer is 100 times more prevalent in females than males? If someone says, oh, you're a sexist, what are you talking about? I'm telling you that breast cancer is common in females. That doesn't make me a sexist. If I say that COVID-19 is more dangerous in old people, that doesn't make me an ageist, in my view. Be interested to hear from the audience what you guys think. Now, I think that ageism occurs when we don't protect very old, demented people who slide into intensive care unit care because they haven't filled out yipui koach mitmashech, clinical guidelines. I think that's maleficence. I think to put a demented person on a ventilator for COVID is a crime. I don't think it's a question I think it's wrong. Okay, now not everyone will agree, but I think if they understood what they were involved with, they might not agree to it. And what my friend and colleague, Professor David Oliver in the BMJ writes, which is even more scary, he said, what's really ageist, and here I'm going to break my own rule and read the slide. I'm sorry, sometimes you do it. This is the exception that proves the rule. He says, it's ageist as a collective fear of aging and death in the media and society, meaning that appearing old is seen as being diminished, invisible, and unvalued. And an example of that is every night when we watch the news, they tell us that so and so many people have died from COVID, but they were past 80, as if that doesn't matter. So it's a problem. We have to be really careful what we say. And he claims that there are healthy elderly that look at sick elderly and they other them, and they say, oh, I'm not like you. I'm a healthy older person, not like you, a sick old person. And my friend David calls this gray on gray ageism, which is an interesting comment. Just a couple of words, since, as you know, many of you know I have interest in global health. If it's bad in rich countries, what about low-income countries? They've got real tsuras. They've got real problems because the 3 things that we said, hand washing, the availability of soap and water is not taken for granted. The ability to social distance is not easy. Many in low-income countries, sometimes 2 or 3 or 4 generations live in the same household. So the older people can't social distance, and they can't afford, or they aren't available, face masks in those countries. How can we help older people? Well, I've alluded to this already. Under beneficence, how can we help them? Give them good advice. Give them good advice, not bad advice. Make sure that they have enough food, and medications and social contact. If you give people good advice, you strengthen their autonomy. If you look after them, you're being beneficent. If you ensure that the system is not overwhelmed by too many people requiring ventilation, this will benefit both young and old. And this will increase distributive justice. We don't have time to go into the problem of triage, but if our numbers keep going up, we're going to have to deal with triage. Triage is mune, the choice. How do you choose between and among people who need ventilation? And I think the most important thing for beneficence is those people that cannot or do not want to get sick with COVID, who cannot be ventilated because there aren't beds, or do not want to, using their autonomy, those people have to be insured of a death with dignity. And we can provide that in most cases by providing liberal amounts of oxygen in a face mask, not necessarily a ventilator, and morphine, which makes you not care that your oxygen saturation is 50. You don't feel it. So I think that we have to increase our ability to provide palliative care for those people that either choose to not enter into intensive care, or who cannot enter intensive care because we don't have enough beds. What about the next wave? Well, we're in it already. And remember that the 1918-19 flu had 3 waves, and the second and third were worse than the first. So let's not be surprised. Let's be ready. I think that, you know, I'm quite involved in the Ministry of Health. I know what's going on. It's a small country. We know everybody. Negev knows them, and I know them, and we talk to them. The biggest crime of the Ministry of Health was not that we didn't see this coming, that we weren't ready with PPE, ventilators, and proper masks, because we knew this was coming. We didn't know it was COVID. We thought it would be flu, but we knew that a pandemic was coming to Israel, because every 100 years, or more frequently, there are pandemics of respiratory disease. Whether it's influenza, whether it's COVID, doesn't matter. We should have been ready. And we had contingency plans, but nobody followed them. The fact that we weren't ready with testing is a crime, because we should have seen it coming. Okay, and I think I've ended on time. And I'm going to now I'm going to go to Noosh. I want to get rid of this, stop share. I'm going to open up the audience and be very happy to take complaints or comments or compliments or nothing. So, Rami, back to you.
One comment, Mark, you gave me the wrong time. You told me
Oh, sorry.
9 o'clock Eastern Standard Time. It's lucky that I'm always early in my life, so I logged on a half hour early. That's why I came late.
My apologies. But this gentleman is Professor Michael Gordon. He's a geriatrician and internist, and was and is my mentor. And the reason I went into geriatrics is this fellow. So anybody who's angry at me for what I said, please blame Michael.
I can take a
Michael,
look.
Michael, do you want to tell us what's going on in Canada for a minute? Do you have some comments you want to make?
Politically? I'd rather talk about the United States.
No.
Well, I mean, I think for the most part, you know, it's a problem because I read and watch American media. I can't help it because of my heritage. I was originally American. I think we've done well within the framework of the Western world. We've done well. We were behind, as well as you said. We weren't as prepared as you said, but we've caught up pretty well. Testing is now readily available. It takes a little bit longer than it should. I'm part of a group that looks at COVID and long-term care. We have a committee, a provincial sort of committee, and the biggest problem that's come up, which I'm sure is the same problem you have, and that's isolation. You know, they put down policies that make it very difficult for residents to get out. And they just upgraded it to say, yes, now you can have a visitor, but you have to go get a COVID test before you visit. Well, that's crazy. I mean, most of these residents are in their 80s and 90s, the children are in their 60s and 70s. Getting a test is not so easy. It's relatively easy, but still for most of them, you have to drive somewhere, wait in line, even though the line isn't 8 hours. So there are things that really have to be improved. In terms of the economy, the one thing I can say that the federal government did, which was very good, early on, they put in supplementary incomes for people who lost jobs, out of work. I know my kids lost their jobs and couldn't get jobs. It meant a big difference, even though they had the Bank of Gordon behind them. Still, I'm retired. I don't have a huge income anymore. I never had a huge income. But still, that was a very good, clever backstop for the horrible unemployment financial problem. I think we've done relatively well. They just introduced today, literally, mandatory masks, Bakomako. And I just was reading the paper before I came onto the presentation a bit late, is that in fact they started yesterday. It seems to have worked well. You don't see a lot of conflict. They were out with their cameras showing picture on the street, and for the most part, well, Canadians, as you know, Mark, are a terribly compliant, wonderful group of people, wherever they come from. It's like you come to Canada, you breathe a couple of mouthfuls of air, and suddenly you become a nice person.
It's true.
And of course, my friends and brother-in-law in Israel have told me the difficulties now with the resurgence and also the avoidance of masks. It's an amazing observation. The number of people, I mean, it's worse in America, you know, it's my right, it's my constitutional right to carry a gun and not wear a mask. I mean, that's like, comes with a special card you get, gun carrying maskless. I mean, the Lone Ranger would not have done well in Canada, in the United States. Anyway, that's sort of what's going on here.
Okay, thank you.
I think we're okay.
Okay. Thank you, Michael. Any other comments or questions? Nadav.
Thank you. It's a great lecture as usual. I got disconnected for 5 minutes because of connectivity. I'm finally at home, so I can hear well.
Okay, great.
What I want to ask you, Mark, is, you know, in many ways, we're always saying that, you know, COVID-19 came on top of pre-existing issues and structural problems. And because of your experience also in the Ministry of Health, and since also Carmel is listening and we're trying now to think forward how maybe to leverage the current situation and do some reforms. So can you tell us, I don't know, if you were now the Director General of the Ministry of Health, or I know it's a big question, but
yeah, it's a good question. No, it's a really good question. Yeah.
How we can leverage it, and what would be the priorities, or like a roadmap for changes?
Right. Good. That's a really good question. And Nadav is a specialist we probably all know who Nadav is, but for Michael, Nadav is a specialist in public health. He's head of the School of Public Health at Ben-Gurion, and with a lot of experience. So Nadav, I have an article I'm going to write. No one can copy this. And Michael, you look out, because I know you're a good writer. It's called The Silver Lining of COVID. In other words, when we get through this, what will we have gotten out of it? And I think, and I hope that what will happen is a much greater respect, dafka, for Nadav's profession. I think that what's happened is public health, you know, it's not as sexy as neurosurgery, and you guys have struggled so much. I think people will have to understand the importance of public health in the whole healthcare system. I think that you guys will be upgraded. I also think that related to that people are going to learn this business of the economy versus health, economy versus, you know, Torah and Kemach. I think we all know that. The people who are watching this are all literate, but many people, even physicians that I talk to, don't understand the connection between social inequality and health. And I think that what comes from this from this crisis, people will understand that better. Thirdly, I hope that, and this has to do with the unfortunate, I think it's unfortunate, resignation last night of Professor Sadetsky, who Michael was the sort of the lead epidemiologist in the Ministry of Health, and she said she resigned in anger, saying, "You didn't listen to me." And I don't know if they did or didn't, but I think that what the ministry needs to learn, and it's not because of this problem, they should always be consulting outside people. There should be a kind of COVID a cabinet that brings together different disciplines. I'm not against the physicists being part of this. I mean, in Israel, for some reason, the physicists have become the controlling deciders here. I don't know. I know that they deal with small particles, but they're not the same kind of small particles as viruses. And I listen to what they say sometimes, and I actually like physics a lot. It's a bit of a hobby for me, but I can't see how physicists should be running the show. I think physicists should be part of the show. So the third thing I think might happen and hope will be the multidisciplinarity of health that will bring together clinicians, public health people, physicists where they're relevant, sociologists, anthropologists, ethicists, because these issues are all important, and when we make decisions, we need to bring all those voices in. I hope that will happen. And I think we have an opportunity.
Chezi Levi started already every Thursday morning, and if you like to join, I can ask him. He is now consulting a group of people from different disciplines.
Okay.
It's very different than Bar Simantov.
Right. Okay. So what I recommend to you is to tell him he should have a geriatrician. He should have one geriatrician. It can be me, be somebody else. Doesn't have to be me, but there should be somebody who knows something about care, clinical care of the elderly, on that call. And I would be happy to do it, or tell you about someone else who could do it. But yes, I think that's great. And I think, knowing the little I know about Chezi, I think he's Michael. He's the new Director General of the Ministry of Health. I think he'll be more open than the previous one. I think Bar Simantov did a good job, and it's a tough job. But I think he was too ricusi. He was too concentrated in his. So that's how I see it.
Looking for an Auslander to join, I would be happy to, and I'm fairly fluent in Hebrew.
Yeah, you know what? If they ask me, Michael, I'll ask you to come along, and you can be the Lone Ranger, and I'll be Tonto, or the other way around. Yeah, what do you mean, we white man? Remember that joke?
Well, you heard that Trump said he likes the idea of a mask because the Lone Ranger wore one.
Oh, he said that?
Yeah, but it has to be a black mask.
I see. Okay. Carmel, did you want to say something? Yeah, unmute yourself, Carmel, please.
Yes, please. Hi.
Yeah, sure.
Thanks. It's a great lecture. It was as good as the other one I heard last week as well, even better maybe.
I'm getting used to it.
What I'm curious about in terms of the clinical care of old people who do contract the COVID. And you know that I have a personal background. It's a personal thing between us. Mark was a person who facilitated my father's death at home many years ago. So I'm wondering about whether this might be the beginning of a change in where we die, because it does, for me, there doesn't seem to be much point in taking old people, especially with comorbidities, to a hospital to die. And can we develop more home care for old people? And would this be a right direction to go?
Yeah. No, it's a great point, Carmel. I could have added that as a fourth thing to my response to Nadav, that the whole business of home care and telemedicine, they're not the same thing, of course. But yes, I hope that the sensible care of older people, in particular in Israel, because in Israel, as opposed to Canada, where Michael lives and where I come from, we have a sometimes irrational view of what we should do to older people. I think what I helped you with, and we won't go into details on the screen, but it was to take a realistic view of what can be done and what can't be done, and to look after an older person in the most humane way possible. So yes, I hope that from this crisis, people will realize that not every old person who stops breathing needs to have a team jump on his chest and ventilate him. Now, apropos of that, and this is more your field than mine, we have a problem in Israel that so few people at any age have signed advanced directives, or Yipui Koach Mitmashech. How do you say that in English?
Living will advanced directive.
The power of attorney. It's an
power of attorney. Thank you. Yes.
Durable power of attorney.
Power of attorney. So I think that if it comes out of this that 50% or 40% of the population will sign enduring powers of attorney and just have a family discussion, which I had a month ago with my kids. I said, kids, we're going to tough times. I'm not saying my wife's a doctor and she works every day in Hadassah. I said, who knows whether mommy's going to get sick and I'm going to get sick. You should know what our philosophy about this is. We had a family chat. I think it's a great point. I hope more people will do it. But you know, denial's a very strong psychological mechanism. The opposite could happen. And I think it's our responsibility as healthcare professionals to ensure that the natural desire to sort of pull the covers over your head and hope that things won't get worse, that we will help people to open their eyes and do the right thing in their own interest. I hope, but I don't know. Rami, you're the boss.
Yes, I want to ask you a question. Well, I'm not a statistician in any way, so I'm taking the what you said. How do you say it? Face value, that it's independent variable. So, but I was wondering, do you also have, or do you know if there is like a causal explanation that is the mechanism, and is it different for all the people, and could there be a specific medicine that is suited for all the people for this virus? I know it's, you know.
That's a great question. The simple answer, and maybe Michael can chime in, we don't know. We don't even know why people die of any disease. You know, when I look after a lot of old people and I go to a lot of shivas, you know, shiva, and people always ask me, but what did my mother die of in the end? I said, well, she was 98 years old and she had a fever. But what was it that killed her? We don't know why the light goes out. But your question is a good one. We certainly know a lot more about this disease than we did 4 weeks ago, 8 weeks. I'll give you a simple example. At any age, when you put someone in a when you put a tube down their throat and breathe for them, you know, hanshama, most people were nursed lying on their back. It turns out, to our surprise, that if you lie people on their front, on their belly, and do the same thing, they survive better than if you lay them on their back, which is a simple thing. So I think we're learning as we go along. The vaccines that are going to come, we hope, will protect the elderly, because they're the ones, from, you know, taking at face value what I said, they're the most vulnerable. But we also know from the flu vaccine and other vaccines that take-up, the response of the older body to a vaccine is usually less robust than a younger body. So we may have a vaccine that works more in younger people than old people, and leaving the older person still exposed. This is all, you know, we don't know. But the other thing, to try and connect your question to Nadav's question, what I didn't say, and what we have to not forget, is there's never been a time in history where everybody is talking about one disease. Now, there's an opportunity cost to that. We're ignoring cancer, we're ignoring heart attacks, we're ignoring vaccinations of children. I'm not saying that there's a cost to that, but never has there been so many people so concentrated on one problem. The polio vaccine took 50 years to develop because people were, you know, it was a bad disease, but people were, you know, not everybody was a virologist. People were dealing with cardiac disease and gynecology. Everybody's a virologist. Everybody's an epidemiologist. Everybody's working on this. So I hope we'll have medicines and vaccines that work in older people. The interesting thing, just the severita ozen, just a curiosity, was the flu epidemic of 1918 and 19 let old people off the hook. Most people who died of the flu epidemic in 19 were young men, otherwise healthy people. Probably that was ignited in younger, healthy people who can really, when you get their immune systems going, they go crazy. So the reason young people die from COVID is probably an overreaction of the immune system called the cytokine storm. The reason, this is a theory now, that's probably true. What I'm going to say now is theoretical and no one knows. It's possible that the reason old people die is not a cytokine storm, but an inability, a loss of clinical reserve, where otherwise normal little things that wouldn't kill you would kill them. But we don't know that yet. That's a hypothesis. We're waiting to see what we learn, and we're learning a lot about this disease every day.
Mark, Anat and I need to leave for University of Michigan. We have it's funny because every year we have interns, as you know, and this year it was online. We still did some interesting work with them. I want to finish saying that this morning I read on Haaretz, and Anat will appreciate as well, that people that are used to see sci-fi movies and apocalyptic movies are more adapted to react to COVID-19. So
in a
that's
positive way.
Yeah, in a positive way.
Okay.
Yeah.
How about
Bring-
Wonder Woman? I mean, that's a local film. You got a local hero. If you watch
Wonder Woman. Okay,
you're
so Nadav and Anat, thank you. I think, Rami, I don't like to go too long. I like to get a good evaluation by not going on too long. So it's up to you, but I think we can say goodbye to
I'm sorry, I don't want to stop. I think that other people want to ask questions. So thank
Okay.
you so much. It was fascinating, Mark.
Thanks
Thank
for
you.
coming and bye to both of you.
Right,
Thanks.
nice
Let's see
meeting
if
you.
there's anyone that wants to ask.
Anybody else?
Anybody wants to ask a question or a comment?
Can't anybody disagree with me about something? I don't like all disagreements.
Thank you, Mark.
Yeah, Yael, Uri,
Come on.
That was
Stav,
a
Tuvia.
very good lecture.
Two of you got nothing to say to criticize me?
No, not at all. Not at all. I was very interested.
With enemies like this, who needs friends?
No, a lot of things to think about.
Okay, thank
And,
you.
it's very interesting.
Thank you.
Very good.
For policymaker, it's a lot of things that should be considered for the future, the near future.
Yeah. Well,
They appointed, the ministry, I think, appointed Professor Gamzo at some point to deal with the elders at the elderly homes.
Yeah.
I don't know what happens now. I don't know where he is.
No, I'll tell you, that's an interesting question. Michael, you'll find this interesting. This is worth 2 minutes. The ministry the nursing homes are very, as you know, nursing homes are very dangerous places for COVID because people are very old and frail, and because they're living close together, and because multiple people are caring for them who go in and go out. Whereas if you're stuck at home like me, it's just my wife and me, and as long as she doesn't get infected, I'm okay. But in nursing homes, the risk around the world is much higher. And we know that in France and Northern Italy and the UK, thousands and thousands of old people have died in nursing homes.
Canada also, yeah.
And in Ontario and in Quebec too, Montreal in particular. Despite how nice Canadians are, they killed off their old people in nursing homes for some reason. But the ministry, to its credit, took a real bulldozer, Ronnie Gumzu, who's a very intelligent and hardworking guy, who's presently the Director General of Ichilov Hospital in Tel Aviv, and gave him a special task. And within 2 or 3 days, he drew up a Magen Avot, like a kind of a plan to protect older people in nursing homes. And it's ongoing now. And since Rami and I and a few others and Stav are from Ben-Gurion University, and Nimrod Maimon from Soroka has taken it over, and it's working very well. They're testing, they're watching, they're surveilling, they're doing a really good job. And so, not surprisingly, we don't see a big peak of deaths from nursing homes in Israel. I hope that will, as the numbers rise, I hope we're going to see more deaths, but I hope we won't see an epidemic in the nursing homes. And that's in large part, I think, due to the program that Ronnie Gumzu started and that Nimrod Maimon is continuing with under the aegis of the Ministry of Health. Yeah, good point.
Yael, you wanted to say something? Yael?
My usual question about visits. I'm worried about palliative care is one thing, but also isolation when you're so sick. It really worries me more than death. So
yeah, you're right. This is a terrible disease to die from because you can't hold the hand of your, the people can't. It's a terrible way to die, because until this disease, if you were dying and we knew you were dying, my father died in hospital. I was with him. For like 7 days, almost 24/7, and I was holding his hand when he died. I watched him. Knew I was there. He knew that his kids were there, and we were kissing him and hugging him and holding his hand. And God forbid, if that were, I'm glad my dad died before COVID. I'm not glad my father died, but I'm glad he died before COVID. Because if he'd had to die with people, spaceships, astronauts walking in the room, and people can't come in very much because they're busy. It's a terrible, terrible thing, this business. I don't know what to say except that it's terrible. I guess
So
the most...
how come that 4 or 5 months since it started and we see no sort of solution?
Well, we know more than we did, Yael. We do know more than we did.
But for visits,
Yeah. For visits, for infecting people, you know, who's going to visit who isn't infected? The only people who can visit...
so many people now already know that they were sick.
You know,
know that they're not so much endangered.
You know what? I thought about that today. You know, we have 1,000 per day in Israel, which is high. And I was doing my exercise walk and I said, okay, 1,000 a day times 365, right, is 365,000. Let's say it's 500,000. Let's say in a year. Israel's almost 10 million. It'll take us 20 years at that rate for everyone to get infected. So...
Yeah, but why can't the ones that have been infected already take care of the ill? Why isn't there any social system that...
You're right. You're 1,000% right. I wrote a document recently, which is, I hope will get published, in which I say exactly that the people who were sick should run to the front of the line and say, where do you want me? I'm immune. I'm Superman. Now, first of all, we're not...
I fantasize about getting sick. Of course, I don't want to be sick.
No, but getting mildly sick.
The worry that, you know, that the elderly in my family will die alone.
Yes, you're right. I understand. I do. The trouble is we're not entirely sure that if you get sick, you're immune for the rest of your life. We don't know that. You're probably immune for a while, but not the rest of your life. Anyway, this is a nightmare. There's bad things going on, but you know what? Better the public understands them than doesn't understand them. It's better to know than to not know, in my view. It's better for the ministry to have Nachman Shai out there every day talking on channel news, explaining to the population what's going on. We've got different people. Every night there's a different person on the news saying conflicting things. It's terrible. Like, it's hard enough for me to understand this, and I've spent 6 months just looking at COVID. What about regular people? We're giving them bad and confusing advice, and that's the Ministry of Health. In fact, if Nadav invites me to that meeting on Sunday morning, if they give me a chance to speak, I'll say, Chezi, who's the Mankal of Misrad Abroad, Chezi, have a spokesman, not Bar Simon Tov, not you, someone like Tuvia, someone who can get up there and say, ladies and gentlemen, I've been at every meeting, I know what's going on. Here's Tuvia, I've got a job for you. Why don't you become the spokesperson? You'd be a great spokesperson. Who votes for Tuvia? Put up your hand.
Thank you.
Without even knowing it.
Thank you for that. No, but I agree with you about, you know, very clear voice, one voice that give, you know, the audience very exact information and not conflicting messages and stuff like that.
We had that during wars, I know. We're good at wars in this country, but we're not good at wars against viruses.
I'm going to sign off.
Stav, can you tell us 2 words about this research thing we're doing, just because people are so interested in social isolation? Just not to boast, but Stav's the lead on a project that I'm involved in, but that deals with trying to deal with this exact problem. Stav, can you tell us just 2 or 3 minutes about it for everybody?
I will. I probably have only one or 2 minutes because I'm already late to pick up my kid from the kindergarten. But I will say that we are trying. I will say that we are trying to deal with the social impacts of the COVID-19, and I think what is most important. Well, Yael talked about people who are dying alone, and we are dealing with people who, well, now maybe less, but who sit alone at home, lonely, disconnected from their family and friends. And this also has very adverse health effects, physical and mental. And I think this is also something that we should take in account, because the impacts, the long-term impacts of this very long social isolation, this is something that we'll have to deal with in future. I mean, not only from the COVID-19
But tell us about the project. Tell us what you're doing to help with this.
The project we developed is creating digital groups for older people through Zoom. It's a short-term intervention that we teach people techniques and skills, cognitive and behavioral techniques and skills to deal with distress and to bring them together in a virtual space that they're not usually used to, and try to help them to deal with this very new reality, which will very well will stay with us for a long time, coming and going, second wave, third wave. So this is our project.
Right, thank you. And it's a research project. It's an intervention, but we're studying it to see if it works or not. So thank you, Steph. Okay.
Sorry, I have to
no,
run.
Go. Go look
Sorry.
after your kid. First things first.
Sorry, just Mark. This was fabulous, I could tell you.
Thank you, Mike.
But anything that you're doing of this nature, remind me, because I would love to. I mean, I'm not doing a lot of things these days. I'm at home.
You're writing, aren't you?
Yeah, I'm writing, but still, I'm home. I really, you know how much I love Israel. And I mean, if you did it in Hebrew, I'd struggle a bit, but I could do it if you felt that you had to.
Okay. Okay.
But anything, and if there's anybody interested in speaking to me or writing to me, feel free. Mark can give you my email address.
Yeah, you can write to me and I'll give you Michael. Michael's a good writer, a good researcher, a good clinician. He knows a lot. And I'll let you know what's going on, Michael.
Sure, absolutely. This is wonderful.
Yeah. No, you're not a nitpick. Okay, so I think people are voting.
Yeah, people are
voting. So let's say goodbye.
Yes. So thank you very much. It was beautiful. It was interesting, moving, and thought-provoking. Everything. Thank you very much.
Made my day.
Thank you, everyone.
The only thing missing was a good cup of coffee.
I'm going down to make one now. I'll make you one too.
Yeah.
Whoever figures out how to do a digital coffee
To
get
beam
the double Nobel Prize.
That's for sure.
Okay,
bye,
bye-bye.
everybody. Thanks for organizing
Bye,
this.
everybody. Bye. Thank you very much.
Bye, everybody. Bye, Lana. Bye, Michael.